Sure, Tato. Thanks everybody for joining us. Good to see such a nice big crew and so much interest in the IDI in the VHIN seminar series. Really good to have everybody here. Um, it's my absolute pleasure to introduce Ellie Johnson, who's a PhD student here, so no stealing her for the moment. She's absolutely committed to this. Um, Ellie joined our housing group, He Kāinga Oranga, about 2 years ago, having had a background in statistics and a master's from Massey, which she did very well, including some very interesting Bayesian statistics that I always enjoyed quizzing her about. Um, she's done very well with the group, and she's been doing. She previously did some tobacco research with the Aspire group. That's a research against tobacco use, it being public health. Um, and um, and Ellie's then joined our housing group, where she's mostly worked on what she's going to be talking about. But really, the thing I must say, and I really admire about Ellie, is both the quality of the stats and the work she's put through on the stats, but also the very hard work of talking to the community, making sure that their voice is heard and that we're getting their data off them and we're interpreting what they're trying to say to us with their data and making sure that it sits together with other qualitative and quantitative bits that gives it a holistic picture. Um, and Ellie's been really good, and there's 18 different community groups, and working with them, with all of them, to talk them through the data journey and the rather long journey of once you give our data to us, we collate it and then put it through give it the stats, put it on the IDI, and then it'll be about 2 years later before we're coming back to you with an answer. So that nice, patient, thoughtful way and manner is an absolute makes Ellie an absolute treasure, and I'm really looking forward to her and listening to the talk. So Ellie, if you want to lead us off.
Kia ora, everyone. Thank you. That was such a nice introduction. So yes, thank you everyone for coming along today. It's really exciting to see so many people, as well as some familiar faces. So the work that I will be presenting today is about the Healthy Homes Initiative, which is about improving health through housing. So as Neville said, I'm a PhD student, and Neville is one of my supervisors, and my other co-supervisor is Dr. Eleanor Chisholm, who has done a lot of work in this space too. It would not be an IDI talk without the classic Stats and Z disclaimer. But first, I'm just going to start with some background. So the way I intended this talk was that I'm an applied statistician, so it's very easy for me to get kind of stuck in talking about the stats. But instead, I've tried to kind of aim to this talk about the HHI project as a whole, as well as a little bit of background of how this project kind of came to be. So housing and health. So housing is a major social determinant of health. So when we're talking about poor quality housing, we're talking about poor indoor air quality, cold, damp, moldy housing that's too small, so things like overcrowding, as well as hazardous housing, which causes a huge number of injuries every year. So there are a lot of health impacts from living in poor quality housing, and it's also a significant driver of health inequities. So for some stats, so in the 2018 New Zealand census, it was 1 in 5 homes was recorded as having at least some dampness, and about 17% of houses had mould. So it's actually really awesome that Stats is collecting this data, but as you can see, we have a really large scale problem. There is a lot of poor quality housing in New Zealand, and it is making people very sick. So from Lynn Briggs, who works at Te Whatu Ora now, did a paper looking at the costs of housing-related illness, and from that paper, it was an estimated total of 229 deaths annually because of adverse housing. And so sort of on the right here, we have the World Health Organization Housing and Health Guidelines, which was released, I think, in about 2018, and really describes all of these problems that we have with housing. So when we talk about housing-related illness, it's very common to think about our asthmas, bronchitis, and our lung conditions that come from being in cold, damp, moldy housing. But in fact, I was really surprised to see other sort of things of our skin infections. Skin infections, both viral and bacterial, ear infections, and a lot of even like meningococcal disease, group A strep, acute rheumatic fever has all been strongly associated with housing. And actually was nearly 1/3 of acute rheumatic fever patients experienced a potentially avoidable housing-related condition as children before they developed rheumatic fever. There is a strong tie to both of them between housing-related illness and poor quality housing and rheumatic fever, which is a very serious condition. I mean, they're all very serious conditions, and to think that this could be potentially avoided by having better quality housing means that it's an issue that we really, really need to fix. And there are obviously the health inequities that I mentioned, which especially is seen with acute rheumatic fever. If you, for our Māori and Pacific Island children, the sort of the odds of having acute rheumatic fever are so much higher, and really is part of the health inequities that are driven by our crappy New Zealand housing. So I can't talk about housing-related illness and the research that's been done in New Zealand without talking about He Kāinga Oranga, which is the Housing and Health Research Group at the University of Otago, Wellington, which is the group that I am a part of. And this group is led by Philippa and Neville. And it's a multidisciplinary group, which is, we have statisticians, social scientists, engineers, all working towards making sure that we've got Kiwis in healthier homes. And the aim is to translate research into health policy, because if we have health policy, we can have large-scale change. So He Kāinga Oranga, not to be confused with Kāinga Ora, happens very often. And this group has contributed towards not just research in New Zealand, but research internationally. And that is because of the high quality evidence that has been generated from the group. And so this is a slide from another talk that I've done, but it kind of seemed important to leave it here because it shows how the research that we are doing with the IDI, with these programs, gets translated into policy and even informs international evidence. But yeah, my little disclaimer, subject to a bit of politics. That's all discussion of politics, this talk, I promise. But some of the really high quality evidence that has come out of He Kāinga Oranga is the randomized control trials. Where randomized control trials, well, a lot of you will know, are your gold standard epidemiological studies to establish causation. And so in these studies, it's been about going into the community and providing interventions and then looking at people's outcomes to see what happens if we improve people's housing, basically. So the ones that have been done, I mean, I think there's more than this, but these are just a couple. So things like insulation, heating, subsidies towards energy, which did go on to inform the winter energy payment, as well as home injury prevention. So when we do these interventions, we're finding that people are healthier. If you improve housing, you improve health. And actually, a lot of these did go on to inform the World Health Organization housing and health guidelines. But from about 2016 was when we saw the shift from doing the randomized control trials to looking at really using the new technology that was coming out from StatsNZ with the IDI. Of course, the randomized control trials are fantastic and they really do generate very powerful evidence, but there is a lot of time and expense and real sort of resource requirement that goes into them. And being able to use the IDI provides invaluable information, and it means that we're having to do sort of, I don't think that the resource allocation is less, but it means that we can reallocate those resources to providing the interventions as opposed to measuring the outcomes. I do think that there is still an important aspect of having that talking to people and meeting with communities and doing the research on the ground. But being able to use the IDI means that we're not having to do so much labor on the other side. So a quick mention first about Housing First. Housing First was actually the second IDI project from He Kāinga Oranga. Hopefully I don't butcher this too much because this is Neville's project, but really can't talk about the HHI, the Healthy Homes Initiative, without talking about Housing First, because it has been built on that foundation of what was learned with Housing First. So Housing First was about, was working with the People's Project up in Hamilton. And it is, so Housing First is the idea that we take instead of taking homeless people and putting them through sort of the emergency housing, the transitional housing, and having all these contingencies of people having to attend meetings for or potentially other issues, having to get people to jump through hoops. It is about giving people housing first. If we give them housing first, then there is far more, it gives people more autonomy, and there is far more sort of, how would I put it? It's about empowering people and taking away all these barriers. And so this was a cohort of about 390 people up in Hamilton. It was a homeless cohort who had a really high rate of service usage leading up to engagement with the Housing First services. And actually what was found was really groundbreaking, was that formerly the idea has been that with homeless people or people experiencing housing insecurity, they don't exist. This is an invisible population. How can we do anything how can we put policies in place when we can't research people? These people, they don't exist. But actually what was so groundbreaking about the Housing First project is that it showed the inverse, that these people are far more likely to have engaged with government. They had over 200,000 interactions with government services within the 5 years prior to being housed by Housing First. So these people are in the system, and actually at a higher rate than the estimated resident population indicated. So the stats that I just put are the health, justice, and social development and tax. But there is a far higher rate than firstly what we thought, or what has always been said. But it really shows that these people exist. And if we can show that these people exist, then we can create policy that is informed. So moving on to the Healthy Homes Initiative. The Healthy Homes Initiative was based on that foundation that I've talked about of the randomized control trials and the shift that we saw kind of coming out with using the IDI, coming out from the stuff learned from the Housing First project. So the stuff that I will be presenting today is from the 3-year evaluation report that Neville and I did with Lynn Riggs and Nick Watson from Motu, which was a government report we did for Te Whatu Ora. So the Healthy Homes Initiative, or the HHI, is a community-led multi-component housing intervention program, which is delivered by community providers, most of whom are either Māori or Pacific providers. And it is aimed at low-income families, and the aim is to have children living in warm, dry housing to reduce this burden, reduce this prevalence of housing-related illness. So it was started in about 2013 as part of the rheumatic fever prevention program, and it's partially funded by Te Whatu Ora, but they do all the program management. And the point of difference for this intervention program is that sort of internationally what we see is that a lot of housing intervention programs are about moving people to new housing. So moving people into different neighborhoods, changing people's housing by moving them to a new house. And actually for the HHI is about improving the housing stock that we have, improving the housing that people are in. So the diagram that I have is just shows some of the interventions that are done as part of the HHI, things like floor coverings, mechanical ventilation, referrals to other services, insulation, heating, curtains, mold removal, draft stoppers, minor repairs, and actually and education information, as well as bedding and beds, because so many of the bedding that we see is contaminated with mold. But quick shout out to Variety, the children's charity who do all the beds and bedding. But it is a multi-component housing intervention program, and the interventions provided depend a lot on what can be provided by the community providers of the HHI services. So this is kind of the list of all the different interventions, but it will depend on each the resourcing of the HHI of what is actually delivered to the house. So there is a little bit of variability there. So who was in our HHI cohort? So we had about 21,300 referrals, and that is the data that we took and put onto the onto the IDI. Sorry. So the idea of it is that a child or a person will be referred to a HHI, their local HHI, and then someone from the HHI, a trained assessor, will go into the house, do an assessment of the house, see what needs to be done, and then provide the interventions from there. So the data that we have is from the assessor who has gone into the house, who has met the family, talked to them. And so the data that we have is actually really, it's collected by people who don't do statistics. So there is that understanding there, but we're very lucky to have that data. And we're really lucky to have the engagement with our providers. And because of that, it is one of the real strengths of the program. But from our 21,000 referrals, the data that is on the IDI, we linked that to about 14,700 households, and about a cohort, so a household cohort of the referred person plus their family, about 75,000, 76,000 people. So we had quite a young cohort. 61% were under 25, which wasn't hugely surprising because the intervention is aimed a lot at children. But we had a high proportion of Māori or people who identified as Māori or Pacific Islander. We also kind of saw very similar statistics to what we see. You know, there is an interaction between poor quality housing and not being in your own home, or an owned home, I should say. So we saw about 37% of people were private renters, and sorry, about 37% of households were private rentals, and another 37% were in social housing, Kāinga Oranga housing. We only had about 17% who were owner occupied. So we've also updated our linkage methodology a little bit since then, and actually improved our linkage rate a little bit. So now we're working with about 85,000 people, sort of moving on from this work. But our main research question was, what are the health outcomes for participants of the HHI? Have we actually improved housing by improved health by improving housing? So the way that we did this was, again, primarily using the IDI, but we had our HHI referral and intervention data collected by our amazing providers, and uploaded onto the IDI, linked then by Statistics New Zealand using the NHI. And then we linked together our households using primarily census data and DIA data, I believe, but to create that population, or that sample rather, of entire households, because it's not just the referred person who receives the benefit or the impact of the housing improvements, it is them plus their household or the other people who are living in the house. But to analyze the hospitalization events, we retrieved the hospitalization data from using the NMDS, so the Ministry of Health data. We only looked at public discharge data, and potentially that is a possible source of bias. But I think for our cohort, because they are low income, it's unlikely that we'd be seeing sort of people in the private hospital area. But from there, we then looked at the total number of hospitalization events 3 years before the housing intervention, and then compared it to 3 years after. And we modeled this using a Poisson regression generalized linear model. So moving on to the results. So I really have kind of breezed through the statistics a little bit, just because it's not generally something yeah, sometimes it could be a bit dry. But if you are more interested in all of this, it is in the Te Whatu Ora 3-year report that we released and is available online. But looking at our modelling results, we have we do see a decrease post-intervention. So pre-intervention, we see that increase, particularly 1 year before, and that is to do with the eligibility criteria, which is having an interaction with, or having a housing-related illness 1 year before, having a housing-related illness and then being referred to the HHI. So we do see that big peak, but it's really encouraging to see that post-intervention, so 1 to 3 years after the intervention or the housing intervention, we are seeing that decrease, and it's not just an intercept shift. We're also seeing a continued decline, which is really encouraging, and something that we're really looking forward to exploring further. But then looking at the image on the right, or the plot on the right rather, it's the hospitalizations per 100,000 people, and it's the output from our Poisson regression model. And what this shows is that the risk of hospitalization is decreased for no matter someone's age. From the entire range of ages, we see that there is a significant decrease in the hospitalization rate. So we've got a post-intervention, the post-intervention line is significantly lower at all points or at all ages. And what we saw was a 20% less hospitalizations after the HHI intervention as opposed to before. So there was a number of other things that were explored in the 3-year evaluation, and this stuff was generally done by our collaborators at Motu, Lynn Riggs and Nick Watson. But we also saw reduced hospitalization severity, reduced days off school, and reduced benefit income, which is really encouraging because it shows that if we improve people's housing, we're improving health, and this does have tangible impacts on the days that kids are in school. They're more able to attend school, and potentially parents are more able to attend work. With all of that being said, we are looking forward to exploring this further, and there is more work that we will be doing on this. This 3-year report was really exciting to see that sort of large scale, the interventions provided by the HHIs are making a real improvement to the health outcomes for not just the referred child or the referred person, but their entire family. And this HHI program could be a real significant lever to reducing the burden of housing-related illness in New Zealand, at least until we get some better housing policy, and fingers crossed on that. And as any parent of a sick child knows, if you have less hospitalizations, the kids are in school, and there is less of a burden on the entire family, and that whole sort of that individual well-being and how that translates to family well-being and even translates to that community level well-being. This year, it's really, I'm really excited to be working on the 5-year evaluation report. It's crazy to think that it was now 2 years ago that we did this big 3-year report. And I think the data that we've got on the IDI goes from now 2014 to 2022, I believe, 2023. Yes, it is 2023, or the end of 2022. So as of March 2024, when we got the latest iteration of the data uploaded, we've got about 31,000 referrals on there now. And from this year onwards, we will be updating the IDI data annually. Thank you heaps to Statistics New Zealand. They've been amazing. But moving on from here will be that 5-year evaluation report and looking at some advanced modelling and actually seeing how does the HHI compare to an artificial control group. What can we say about what would usually be happening for people? At the moment, we've been a little limited in just saying, well, this is the outcomes for our HHI population, and what would that look like compared to a control group? And that would potentially give us a little bit more powerful sort of conclusions. once again, I think I've said this so many times, is that having the IDI provides us with huge opportunities for this research. And I think it is one of the strengths of the HHI programs is being able to use the IDI. But as I kind of finish up, I kind of thought I'd just put a little this little list together of what I consider as some of the other strengths. A big one as well being that the research is conducted in partnership with the community. We, as Neville mentioned, we do a lot of outreach, so we are continually touching base. It is not that we are researching, these people are our research participants, it's that these people are our research partners. We are continuously talking with the HHIs, and having these conversations is really good for both of us, because it means that their stories can inform our research, and that we can also kind of provide guidance on the data collection. So it's improving our data, and it's also improving the research that we are doing. But other strengths is that I have very strong government backing, and Te Whatu Ora also do the program management. And what this means is that we have a large-scale program, which has gone on for a couple of years now, which means that we can be looking at the longitudinal outcomes. We're very lucky to have those people at Te Whatu Ora who are doing the program management, and are really passionate about this work. But the other strengths I saw was that it is a holistic and effective program evaluation with qualitative and quantitative components. One of the real sort of dangers of the IDI, I think, is that having so much data means that as a statistician, I say this is because I have done it, is that one can trend towards data mining and being very excited by significant p-values and novel outcome, or these novel associations. But we're very lucky to be led by some amazing qualitative research, which has been conducted primarily by a couple of people, but primarily by my amazing co-supervisor, Dr. Eleanor Chisholm, and having that qualitative research to actually inform the path that we're taking, and the research that we're doing really is invaluable. As well as having the IDI, though, it is the balance of the qualitative and the quantitative components. But having the IDI means that we're able to look at what does it mean when we change a social determinant of health? What does it mean when we are changing housing? And how is that translating through to measurable outcomes? And just to finish off very quickly, some acknowledgements of those people that have been involved in this work. Firstly, my PhD supervisors, as well as the Te Whatu Ora program management team, and the HHI collective, including the provider teams, who've once again, they collected that amazing data that we're so lucky to have, but also people who have provided funding. This program is not fully funded. It is only partially funded by Te Whatu Ora. But finally, a big thank you to the HHI whānau who have consented to having their data be used for this research. And actually, one final addition to my acknowledgements is huge thank you to the amazing Statistics New Zealand's team, as well as the wonderful output checkers. And if you have any questions, I think there might be a little bit of time for questions now. But if you think of a question after this, feel free to email me. And if you're interested in this research or any other of the housing research that has come out of He Kāinga Oranga, there is our website address. And thank you very much to everyone who has attended today. It has been really exciting talking about this work. Thank you very much.
Thanks, Ellie. That's absolutely excellent. A great summary of the research and a great idea of where you're at. It was really enjoyable to watch. Barry, you put a question in the chat. Do you want to give it a shout out?
Sure. Thank you. First of all, that was a fantastic talk. Thank you, Ellie. I put in two things, but I took away the first one because you addressed it in the final slide, which is, can I get access to the report? So I'll just go onto your website. The second one was, I wonder, I'm thinking here from a policy point of view, wanting to change policy, whether you estimated cost savings, which is probably most easily done with hospitalizations, although I think they took out the cost weight variable, which is a little bit annoying. But also potentially broader, since you found broader impacts. You mentioned schooling and benefits.
Yeah, so we were really lucky to have Lynn Riggs on the 3-year evaluation report, who did the cost benefit analysis, and it did take into account the hospitalizations as well as the days in school, and I think the benefits as well. I cannot remember the number off the top of my head, which is terrible, but we did do the cost benefit analysis, and it was a very big number, I believe, and I should know it. But we did account for these other factors. So it is in the report, and we will be doing a very similar methodology for our 5-year report. And so it'll be really interesting to see how those numbers sort of take into account 5 years since an intervention.
That was really interesting. You explained a little bit what can happen in this kind of interventions. Can you go a little bit more into detail here in terms of, first, do I understand it correct that basically whatever happened, if anything happened, like in terms of improving the home, then they are in your analysis and in your sample? And do I understand it correctly that basically before we should think there was some issue, and afterwards they were still living in the same home, but the issue was fixed or whatever? Or how should I think of kind of the treatment that occurred? And yeah.
So there's a couple of points. Firstly, thank you. Great question. Firstly, I think we need to be very realistic when we talk about, like, is the issue fixed? The issue is not fixed at all. We really need, this is a sticking plaster, but it is a before-after trial. I think we call it a natural experiment. But the way that it works is that these people will be referred to the HHI, and then there is an intervention which takes place no matter whether there is even sort of provided insulation, because one of the biggest interventions is actually the provision of education and advice. So when an assessor goes into the home, they will be providing information about how to maintain a healthy home. It's very counterintuitive to think heat your house and then open the windows. But this is the problem that we have, is that it's the prevalence of mold and damp. The two go hand in hand. If you heat up a damp house, it's not easy to heat, and you're just going to grow that mold. So a lot of it is about the education and the information. So that is what the intervention that is provided no matter what. But going on from there, there may be there's that variability on the interventions that has been provided. But that is probably our key one. I don't think that we really have the data quality to look at the individual interventions per se, but that is something that we'd be really interested in looking at moving forward. And it is about having those continuous conversations with the providers to see if we can get that data quality to be able to look at what are the interventions that are actually making the significant difference. So hopefully that has, in a roundabout way, answered your question.
Thank you. Yeah, maybe just a short follow-up, because it's related. And how does the first referral really happen? How do people enter the system?
So the referrals, there's a couple of different pathways. You can self-refer. We've also seen family members refer sort of their other family members, as well as medical professionals can do referrals. And we've also seen HHIs do a lot of community outreach. So they will go out to their communities, rugby events, and actually say, hey, if you are having problems with your house, come talk to us. So I'd say those are probably the main sort of referral pathways. Neville, please feel free to jump in if I'm missing anything.
No, the most common pathway is self-referrals by a slight margin, but that probably covers the outreach. Ideally, we'd have all the pediatricians ask about housing and refer people in, but that's patchy at best. But yeah, most majority are self-referrals due to raising awareness. So Mariana is asking, hey Ellie, quick question. How did you control for confounders to isolate the effect of the intervention?
So we adjusted for a couple of different confounders. Our primary one was age. There is a different sort of pattern of a different pattern of hospitalizations for adults and children. So that was the big one we adjusted for. Also, that annoying thing that happened, COVID. COVID was an incredibly terrible thing, but it was also very frustrating for the modeling. So we did have to adjust for that, and we did so very slightly in a way that will adapt moving forward. But COVID very drastically shifted how hospitalizations happened in New Zealand because we went into that national lockdown. So those were probably the big confounders that we adjusted for. I think that there was probably a couple more, but I cannot remember off the top of my head.
Thanks very much, Ellie.
Thank you.
Thanks, Marianne. Len Cook emailed in a quick question asking about where we use the census data. And this is part of a broader point about moving to administrative census, what we'd be missing. And if you don't mind, I'll answer that. So Len, we were using there's a few very important bits for us. The census is the biggest one for collecting the households together. And while that is done, and there's a few attempts at that in the administrative census, the census is a really good, hey, these people were definitely in the house at the night. Or it's also, while we've asked people what type of house they are in and it's recorded, it's also a really good check on who's their tenure. The household information itself, it gives us a point in time estimates of mould, which is either before and after mould, damp, cold, that's collected nowhere else in the data. And it gives us 2 separate time points for that. It's a good double check for a few other things like income, but that can be done elsewhere, income and education. And it's the mental health score as well comes, which we haven't used or displayed here, is in the census. So, and disability are the other things that are probably vital. So yeah, and the scope of the census itself is very important, and everybody's asked it. Thanks very much for that question. And then for Ellie, Sian asked, how do the interventions compare to the wider healthy homes in rental interventions? I presume this is the healthy home standards.
So the healthy home standards, I'm guessing, so that was based on the rental warrant of fitness, which was research done by He Kāinga Oranga. So there is obviously overlap, but one of the really frustrating things about the healthy home standards was that they took out some of things that I consider and that are considered really important. So one of the big ones, and my pet peeve, is that the healthy home standards took out curtains. That's the one that annoys me. So curtains, a big one about being able to ensure that thermal envelope. And that is not in the healthy home standards, but is one of the significant interventions provided by the HHIs. A lot of them have curtain banks. So there is definitely overlap. But yeah, Neville, I don't know if you have anything to add there.
So yeah, so the recommended interventions and the recommended interventionists from the HHI follow a very small expansion on the healthy home standards. The healthy home standards have been very useful because they came in during the rollout of this program, and they've been very useful in saying to landlords, here's the legal standards that you're missing, and that you need to get your home up to it. So as somebody on the governance of the HHIs, we send a lot of carefully worded letters to landlords to say, hey, you're breaking the law. These are the particular bits of the law you're breaking that we've assessed. Please go fix your house. And that's somewhat effective. But as Ellie pointed out, there's a few things missing, curtains and draft stopping and a bit of practical things. So it's we'd like to think that any home well remediated by the Healthy Homes Initiative winds up slightly higher than the Healthy Home Standards, but only marginally. I'd like to really thank Ellie. Hey, that's an excellent job and excellent work, and I think we're all. I'm really excited to see this is a real example of how we work with communities, get their data on the IDI, and give back to them how much impact they've had. I think this should be done for every time we're intervening in a social determinant of health. And I'd really like to thank you for taking a big lead on what I think is a very important one. So thank you very much. And I see lots of other people are clapping too virtually. Well done, Ellie.
Thank you. That's so nice. And thank you everyone for attending and for your excellent questions. If I haven't been able to answer your question, you've definitely given me something to think about. Thanks.